Uh, Good morning, everyone. Welcome to our mask ultrasound Zoom, and we are so privileged to have Dr. Ken Onishi from University of Pittsburgh to share with us his expertise on the future of sports ultrasound. But before we begin, let's just pause for a moment for a short prayer. Let's pray. Heavenly Father, we thank you for this beautiful day. We thank you, O God, for the opportunity that we can learn today from Dr. Ken important aspects of ultrasound looking towards the future. We would like, Lord, to ask for your grace and your goodness. We ask, Lord, that thou will keep us safe and protect us from any harms and dangers. In Jesus' name we pray. Amen.
Amen.
Ladies and gentlemen, introducing to you the one and only Dr. Kentaro Onishi, Assistant Professor of University of Pittsburgh of the Department of PM&R and Orthopedic Surgery. Okay, Dr. Ken, go ahead.
Thank you so much for your kind invitation, Dr. Castro, to this mask presentation. This is my second time talking, and I hope you can hear me well. But we'll go ahead and get started here. Again, my name is Kentaro Onishi from University of Pittsburgh, Department of Physical Medicine and Rehabilitation and Orthopedic Surgery. And today I'll be speaking to you about the future of sports ultrasound Tokyo 2021 and beyond. I have currently 3 research grants from the Department of Defense, or DoD, American Medical Society for Sports Medicine, and Pitt Innovation Challenge. Although none of these topics presented today directly influence the contents of my presentation, I just wanted to have full disclosure. Those of you who may not know me, and I usually start with this slide so that I can remember where I come from. I was born in Tachikawa, Tokyo, and grew up until high school when I came to the United States. I completed all my college work and medical training, most recently completing my sports medicine fellowship at Mayo Clinic, Rochester, specializing in sports ultrasound under mentorships of Jay Smith, Jake Sellen, and Dr. John Finoff, who is now serving as the Chief Medical Officer for Team USA Olympics and Paralympics. My current practice involves the use of diagnostic sports ultrasound and ultrasound-guided intervention, and my research focus includes evaluation of ACL and meniscus injury using ultrasound, ultrasound-guided microsurgeries, and intervention targeted to tendon and ligaments. And of course, I'm involved in mechanobiology researches where we investigate how tendon responds to mechanical loading and how tendon heals. And little update, I just got a notification from Springer that the book that I worked on for the past 5 years is finally in print. So I'm very ecstatic, but as Jim knows, editing book is like giving birth to a child. It's very, very time labor intensive, but I'm really excited to be able to deliver this book titled Tendinopathy, coming from Springer back in January. So if you can watch out for that book, that'd be great. So before we start talk about sports ultrasound, let's get going defining sports medicine. Sports medicine mostly originated from joint replacement focused original orthopedics when orthopedic surgeons realized the specific needs of athletes, which is a swift return to activity and sports. For this, we realized both rapid diagnosis and micro-invasive treatment options are important. Sports ultrasound seems to afford both of these purposes and therefore gained the popularity over the past 70 years. Out of curiosity, Jim, if you're able to comment on this, in Philippines, if one were to become a sports medicine doctor, is there a certification program?
For now, there's none. There's none yet.
So it's sort of like whoever wants to be, and they will need to build the reputation, credibility through research, clinical practice. Is that how it works?
Yeah, but a lot of times they went abroad to undergo training for sports medicine.
So they get a doctor trained in the United States system, and then they get fellowship training in sports medicine and come back.
Yes, right, correct.
Nice. That's interesting. That's kind of what Japan is facing as well. They don't really have like a fellowship training that is year long or so. And interestingly, in the United States, there's a movement away from 1 year sports medicine fellowship toward 2 year fellowship. So it's becoming a lot more stringent and rigorous. It's really interesting to see that how different countries certifies a physician to be a sports medicine physician. But I just briefly wanted to share the history of sports medicine in USA, and it really spun off from a subdivision of sports medicine. The orthopedic surgeons really initially who realized the microinvasive procedure rapid return to play is needed for athletic populations. So I just wanted to briefly talk about and how ultrasound is fitting to accomplish point of care diagnosis as well as microinvasive procedures. So ultrasound is useful, is what I'm saying in sports medicine. Since the first application of ultrasound in musculoskeletal system by Dr. Dusick, we have come a long way in both technology and our clinical experiences. Today, compared to MRI, ultrasound affords much reduced cost of care in the United States. One publication from Thomas Jefferson University showed that if MRI was substituted with ultrasound for diagnosis that could have been made using ultrasound, a single hospital would have saved $6.9 billion over a 16-year period of time. Further, ultrasound has a higher spatial resolution, not contrast, but higher spatial resolution, and is both accessible and portable. And this adds the much needed mobility in evaluation of athlete injuries. Dynamic evaluation is beneficial in cases such as this. This was a female runner presented to our clinic for a chief complaint of snapping posterior buttock pain since a fall on the black ice. You'd think evaluation for this kind of things, ultrasound would be, the first choice for all of us who is here interested in ultrasound technology. But interestingly, our orthopedic colleague decided to go for MRI. And MRI was performed and it showed a degenerated proximal hamstring tendon, but this did not explain the snapping. As such, we had proceeded with a dynamic ultrasound, and you may have seen this, but this is medial and this is lateral. And once again, left side of the image is medial, right side of the image is lateral. And this is just a static images as patient performs truncal flexion. Ischial velocities in the center of the image, and this is the conjoint hamstring tendon sitting on top of it. As the patient flexes the torso, you can see the lateralization of the common conjoint tendon of the hamstring, as you will see in this video as I start. So this allowed us to make the diagnosis of coxa saltans, also known as snapping hamstring tendon, resulting in successful treatment with a double loaded anchor, which is a surgical treatment. But this is just one of those examples where dynamic nature of ultrasound is useful in evaluating athletic injuries. This is the post-operative video of the same patient. What is interesting was the surgeon reported that under the anesthesia, because of muscle flaccidity as a result of anesthesia, snapping was not reproducible. So this case is a great quick case that showcases the advantage of sports ultrasound compared to other imaging modalities that allowed us to provide proper care for this particular athlete. Also, before ultrasound became readily available, our treatment targets were things we could see well with MRI, X-ray, CT scans, such as muscles, tendons, ligaments, cartilages, and bones, and labrum. But with ultrasound resolution, we are now able to both evaluate and possibly treat nerve and fascia. And I believe this is the area of active sports medicine research in the years to come. So just showing hydrodissection. Some people in Japan might refer this as a hydro release procedure targeted to the peroneal nerve in this case. Let's talk briefly about the benefits of ultrasound in sports medicine interventions. First, ultrasound guidance makes the procedure safer. In addition, procedure becomes more accurate. Publication from American Medical Society for Sports Medicine, or AMSSM, nicely shows the accuracy difference between guided versus unguided injections for various joints and soft tissues. And ultrasound guidance always improves procedure accuracy. For example, there's about 20% difference in accuracy for knee joint injection and 60% difference in shoulder joint injection. For the first CMC joint, a study shows there's 100% difference in accuracy between guided and unguided procedures, essentially saying unguided injection is inaccurate 100% of the time. Why is high accuracy so important? Let's go to the next slide. Let's talk about this patient who received a steroid injection to first CMC joint, who did not respond to the injection and reported worsening of the pain. If we had not used ultrasound guidance, it is very difficult to explain why the injection did not work or why injection resulted in an increased pain. Was it because the injection was missed that it didn't work? Or was it because we injured superficial radial nerve? There will be more questions than the answers with unguided injection that unfortunately did not improve this particular patient's symptoms. However, if we had used ultrasound guidance for this particular procedure and we are sure of the accuracy of the injection, then we are able to move on to an alternate options such as dextrose injection, platelet-rich plasma or PRP injection, or an operation even, all while successfully avoiding an injury to nearby nerves. As such, ultrasound-guided injection can give us more answers about the patient than the questions. I would also like to talk about the role of diagnostic ultrasound-guided injection, since I see this in clinics frequently. Say there's an athlete that comes in with a medial knee pain suspected secondary to medial meniscus injury. MRI was ordered and shows some signal in medial meniscus, but also some signal in distal semimembranosus tendon. In such a case, use of an accurately placed low volume anesthetic injection called diagnostic injection can be very helpful. This was a 13-year-old athlete I frequently talk about with 6 months history of medial knee pain, and a diagnostic injection to semimembranosus bursa improved her pain for 1 hour, allowing us to be confident about the diagnosis of distal semimembranosus tendinosis. A little caveat about this specific bursa is that it seems the bursa volume is less than 3 cc based on our cadaveric investigation. So if we are to perform this particular diagnostic injection, it is recommended that we keep the volume less than 3 cc in order to maintain localization of the anesthetics. In the United States, we now have a few FDA-approved ultrasound-specific surgical devices meant to be used for an outpatient procedure. The earliest of such device is called Tenex, and Tenex accomplishes percutaneous tendon debridement or fascia debridement using the local anesthetics. We now have 2 similar devices, namely TenJet and Tendonova, for degenerated tendon treatments. And we also have ultrasound-guided carpal tunnel release devices such as Sonics, as well as Guo wires. Let's briefly talk about the Tenex, as this was the first FDA-approved ultrasound-specific surgical devices. This procedure was inspired by ophthalmology technique called phacoemulsifications, which uses ultrasonic energy to debride the crowded part of the lens in cataract patient and suctions the debrided lens. My mentor, Dr. Jay Smith, had a hand on developing this Tenex device, and this device, as shown, can debride scar tendon tissue or plantar fascia tissue and suctions out the debrided tissue to treat degenerated soft tissue injuries. Currently, we have several case series published for tendon, such as tennis elbows, golfer's elbow, plantar fasciitis, and Achilles tendinopathy. Dr. Merrick Hall from the University of Iowa is leading a large case series to look for the safety of 10X procedure with a goal to run a clinical trial to investigate its true efficacy. Of course, University of Pittsburgh is one of such trial sites, lucky enough to be chosen to be one of the sites for the safety as well as efficacy study. And I'm the site principal investigator for this investigation. And we've so far accumulated data approximating about 4,000 procedure performed under using 10X, showing a high chance of safety for the procedure. So what sports ultrasound accomplished so far leading up to 2020 are two things. One was expedited diagnosis. Traditionally, MRI was the gold standard for much of the soft tissue injuries. And this resulted in multiple clinical visits to get the imaging and to review the imaging. But the sports ultrasound now used in some clinics, not all of it, unfortunately, we are able to gain much more information during the initial visit, resulting in more swift diagnosis in many cases. Mayo Clinic infographics that was published about a year or two ago also speaks to this effect as well, that ultrasound used in initial visit results in quicker return of athletes to activities. Another benefit we are already seeing is ultrasound guided intervention affords the added accuracy and safety for conventional procedures, and also afforded us the use of more surgical procedure in less invasive fashion, such as 10X or SONX, resulting in a quicker return to sports. Now let's shift the gear a little bit and talk about the future and what is on the horizon in sports ultrasound. We, as a sports medicine expert, will need to start realizing that sports ultrasound does not always equal musculoskeletal ultrasound. As most of sports doctors have background in musculoskeletal medicine, our initial tendency was always focusing on musculoskeletal or neuromuscular injuries. However, athletes' need is not always musculoskeletal. For example, a soccer player receiving a ball directly onto her eyes with the development of floaters and quickly decreasing visual acuity. Oh, let's talk about the case of a football player who receives a direct chest trauma who develops difficulty breathing. Or a final case that also had to do with a soccer player who had non-contact, non-traumatic, sudden onset growing pain on the field during a match. I don't know if you guys can see this top screen, but you see the comet tail, which is the artifact of going the whole depth of the images on the right corner. So that is a common finding for pneumothorax. And to the right top corner is going to be a retinal detachment in case of the floater development. And a final case on the right bottom corner, you can see left side is lateral, right side is medial, and you can see the inferior epigastric artery to the left of this protruding mass. And a protruding mass is consistent with direct inguinal hernia. And these diagnoses are possible on the field if you've known ultrasound beyond musculoskeletal system. But I just wanted to highlight some of the cases where the knowledge goes beyond that knowledge and experiences in musculoskeletal ultrasound if you had that training in this type of ultrasound. So, I just wanted to highlight that we must focus our learning on not just on the musculoskeletal system, but things that's outside, maybe in the emergency medicine, maybe in the ENT field, maybe even in the ophthalmology world. And there should be specific ultrasound courses, workshops that kind of emphasizes the needs of athletes. In all three of these cases, ultrasound was instrumental in initial sightline evaluation of these athletes, resulting in more effective triage at the hospital and or at the sightline. But I feel, obviously we will need a training program for these things. And, maybe this is a tall order for us to require all of us to be able to do this right now, but maybe in the future, this is what I hope for, that all the sports physician can perform all these non-musculoskeletal ultrasound examinations. I'm excited to share with you this exciting ultrasound project for Tokyo Olympics. I'm currently working with Tokyo Olympics Organizing Committee and International Olympic Committee, or IOC, to design a study to investigate the benefit of venue sightline ultrasound used as an initial triage tool. Our goal is to see if ultrasound examinations performed at the competition venues during Olympics would add psychological benefits to both competing athletes and treating physicians in diagnostic confidences, as well as, of course, diagnostic accuracy or added value of diagnosis. As ultrasound is a user-dependent skill, as we all know, that seems to be limited by exposure, there's some exciting news. In August of 2019, my alma mater, where I did my PMR residency, University of California, Irvine, became the first medical school in the United States to give out a portable ultrasound to all of the first-year medical school students, with about 10 other schools following this suit in 2020. There's a small video clip of this white coat ceremony at the University of California, Irvine. I wanted to share with you. I can only imagine how great it would be for the future of sports ultrasound if all of the medical schools in the world begin teaching the students on ultrasound-based curriculum.
The UCI School of Medicine has been very innovative since its beginning. When I first saw the butterfly device, I was blown away, and I said, we have to give one of these to each of our students on day one. Seeing the physiology come alive enables students to actively learn the wonders of the human body.
At UC Irvine, you guys graduate with special powers that most other medical students don't have. And that's becoming your reputation. When people see a UCI medical student coming along, they think, oh, that person is going to be able to not just do a history and a physical exam, but they're going to actually be able to look into the body, through the entire body, from the eyeballs all the way down to the heel of the foot, harnessing this technology. So yeah, we're seeing basically 4-chambered view of the heart here. You can see all 4 chambers there. The ventricles are at the top of your screen.
We put a lot of thought into how we can continue to drive innovation and quality in medical education, and came to the conclusion that ultrasound will play an integral role in the future of medicine. So with that thought, we decided that tonight, after you receive your white coat, we will present each of you with your own personal butterfly device. So congratulations, class of 2023. You were the first class in the nation to have their own personal ultrasound device. You are the future. Embrace it and go forward with enthusiasm and passion.
Having ultrasound this early in my practice is really going to help my education.
I was blown away by receiving this butterfly gift. For me, ultrasound in practice is going to be completely game-changing because I'm really passionate about delivering healthcare to low-resource settings, and they don't have things like this.
This white coat ceremony has been by far one of the most meaningful nights of my life. I'm just deeply grateful to have the opportunity to have my family here tonight to show them just how far all of their hard work has allowed me to go thus far. And I'm ready to start walking this butterfly ultrasound device and save some lives.
Certainly exciting. For those of us who finished medical training before sports ultrasound became popular, it has always been a challenge to close our clinic or practice and go to ultrasound workshops, unless, of course, if you're Dr. Castro, then you'll find him everywhere in the world. But it was coronavirus pandemic, ultrasound experts started seeking out the ways to improve remote learning experiences like mask. Remote learning will likely to stay even after the pandemic ends, and will likely help improve the access to sports ultrasound learning. Finally, I would like to see more aggressive use of ultrasound in sports medicine research because that will advance sports ultrasound. ultrasound as a research tool has many advantages relative to sports ultrasound sports researches that was conducted using MRI. For example, dynamic evaluation is only possible with ultrasound, and some sports injuries are dynamic in nature, requiring the use of ultrasound to fully understand them. Another advantage of ultrasound is its ability to better characterize tissues. Ultrasound technology has evolved, and we can now evaluate things like tissue stiffness using elastography, muscle glycogen content using muscle sound, or microvasculature using microvascular imaging. The ease of site-to-site comparison, its portability, and low cost are some of other features that will make ultrasound much more attractive than MRI in certain researches. I would like to use our ongoing investigation to highlight some of these advantages so that I hopefully in the future, people will consider ultrasound in case MRI was traditionally considered. At the University of Pittsburgh, we have and we are investigating a phenomenon called meniscus extrusion, as I'm sure most of us have heard about. Meniscus extrusion is defined as a radial displacement or deformation. No one really knows the ratio between the two. Difference between displacement, deformation is beyond the time allowed for this presentation. But basically when it radially extrudes beyond the tibial cortex, that's called the meniscus extrusion. Extrusion had been prospectively correlated with the risk of osteoarthritis and osteonecrosis development. And this is therefore an important phenomenon to better understand. Much of earlier studies evaluating meniscus extrusion employed MRI, but since this is a dynamic phenomenon, we felt that use of ultrasound made more sense. At Pittsburgh, we are fortunate to have the only 6 degree of freedom robotic machine in the United States. And this was combined with ultrasound. Under various loading conditions, we evaluated normal meniscus extrusion, followed by a creation of posterior root tear in the meniscus, which is frequently missed on MRI in clinical practice. We evaluate the validity of this biomechanical model combining 6 degree freedom robotic machine with ultrasound, and are excited to soon to be able to share with you the results, how valid, reliable this method is, and how this can potentially make us understand this phenomenon called meniscus extrusion better. We don't even know what the normal is right now. There's a wide range of normal range reported so far, and there's room for sort of argument on that. So it's very controversial. But if we can strip off of all other sort of component and really appreciate how meniscus moves under known force and loading, then we can begin to understand what the normal value would be. Another use of ultrasound in sports research at Pittsburgh is its use of evaluating ACL injuries. This is the picture of ACL consensus meeting held last year in Pittsburgh. And the center of all of this was Dr. Freddie Fu. I happen to be next to him in this picture. Freddie Fu, me, only PMR doc in the entire room. Was pretty exciting. For those of you who may not know him, Freddie Fu is the chairman of orthopedic surgery at University of Pittsburgh for the past 25 plus years, who now has over 400 ACL original researches published. He's clearly one of the world's leader in ACL research, and he has been very interested in using ultrasound to evaluate ACL injuries. We have published a study showing ultrasound can accurately measure the hamstring graft size for ACL reconstructions. Same or actually better can be set for quad tendon measurements. In fact, we just had our paper accepted in KSSTA yesterday, advocating ultrasound is more accurate in measuring quadriceps tendon graft in ACL reconstruction than MRI. We also used ultrasound to evaluate anterolateral complex of the knee, known as ALC. Some people may call this or know this as ALL, or anterolateral ligament of the knee. ALC evaluation was originally inspired by publication from Dr. Klaus's publication in 2013 in Belgium. Dr. Klaus published a paper with this section shown here in the middle of the screen, stating that their group had discovered a new knee ligament. In response to this publication, our team performed an ultrasound evaluation of soft tissue in this area. So I was asked to perform diagnostic ultrasound on over 80 fresh frozen cadaver, and discovered that while there is no discrete ligamental structure in this area, there was a fascial structure or connective tissue structure existed that derived contributions from iliotibial band, biceps femoris, and knee joint capsule, creating a fold now we call ALC, or anterolateral capsular complex. Interestingly, when dynamically evaluating ALC with ultrasound, we realized that knee flexion and or tibial internal rotations both resulted in increased thickness of ALC fascia or complex, creating a structure that looks like a ligament. For Dr. Klaus's publication, perhaps the use of embalmed specimen resulted in hardening of the regional fascia or connective tissue, resulting in a construct that looks like a ligament. Age also does the same thing. So sometimes you'll be able to see more robust connective tissue without any flexion or internal rotation in evaluating this area. Let's talk about vascular ultrasound evaluation in sports research. Previous MRI studies had indicated that the vascularity after ACL reconstruction is informative of graft maturation. As such, we began investigating vascularity of ACL from the time of injuries to the post-operative period using microvascular ultrasound software, in this case called the Smart Microvascular Imaging, or SMI. This is just the intraoperative images I was able to borrow from Dr. Fu, showing how vascularity changes depending on the age of the patient, from 20-week fetus, 17-year-old, as well as 67. Of course, there's age-related changes in the vascularity, and we don't really know what the normal value is going to be in terms of amount of blood flow to the area. However, our preliminary result, which we are ready to submit a paper for, shows that the ACL has increased vascularity after injuries before operation relative to the contralateral side. After ACL reconstruction, ACL vascularity increased on the injured side, but to a lesser extent, similar increase of vascularity was also seen on the healthy side. So this is an interesting observation we're trying to make sense out of. So this is how the microvascular package looks like: AM bundle, PL bundle, ACL, intra-bundle septums, and you can see the blue dots, and that is essentially the blood flow within the ACL. So in conclusion, sports ultrasound added precision in sports medicine in diagnosis. Sports ultrasound improved physicians' ability to listen to athletes' voice better. As Dr. Sir William Osler said, listen to your patients. They are telling you the diagnosis. From the time of Dr. Sir William Osler's time, fast forward several decades, we are not only able to now listen to patients' brain with astute history taking and listen to their body by physical examination, but we now have the ability to listen to their injured tissue using ultrasound technology. We must, however, moving forward, do due diligence to the technology of ultrasound and conduct research and continue to publish the data. It's good to have expert opinions. It's good to have local experts that can treat the patients well. But those knowledge needs to be shared so that the entire field of sports ultrasound can advance. I know that writing and papers and publishing papers are tedious for most of us, especially with a busy clinical practice, family obligations. And publishing papers sometimes is even political too. But diligence can ultimately convince naysayers of ultrasound to build the future of sports ultrasound. So I urge everyone who is here to think about writing up a case report, case series, or maybe even conduct more intricate hypothesis-driven studies. Well, thank you so much for your attention. I know that it was scheduled for hour, but just wanted to ensure if there's any questions, answers that I could help with. This is my contact information, and I'm happy to answer any questions you may have.
Thank you, Dr. Ken, for that wonderful lecture. It was really mind-blowing, and you have introduced new aspects of ultrasound, which may be so new for a lot of people. And I appreciate you for introducing imaging, and of course, elastography, and of course, recently also we include contrast enhanced ultrasound, which are all good for enhancing our images. So thank you so much for really doing all this. And I appreciate you for also introducing the ALL.
Yeah. What do you think of this? Like, it's a very controversial, like less to us, more to our orthopedic colleagues. And there's, dichotomizing opinions on this. But then even the people who believe that there was a ligamentous structure initially, I think they're saying that it's probably a complex. And, being aware of, I think there's some people tuning in from Japan earlier. Japanese folks have, latched on to this idea of understanding fascia and how fascial injury can sometimes explain the painful condition that, myotomes, dermatomes, or, spinal nerve root theory cannot explain. So, I think that this is probably like a fascial complex rather than a singular ligament. In fact, most ligaments, maybe with the exception of ACL or intra-articular ligament, I think it's really not a true ligament. Like, ATFL, like ATFL has two components, and the inferior one is essentially like a joint capsule. So I think it's probably a soft tissue construct that complex rather than a singular, discrete ligament structure. And then we took a biopsy of the proximal ALL area, and we found out that there's a lot of myoblast. So the proximal end of the ALL tissue has characteristic of muscle tissues, right, which once again, argues for that that proximal end, it should be more osseous if it's a ligament structure, like a bony, as opposed to muscular. So, those are things that makes me think that it's probably not a true ligament in the sense that it doesn't connect from a bone to bone.
Yeah.
So,
but it's good that you really make it straight and direct to the point, because if you read a lot of papers, you'll get confused. And I would say you're the only person who said, of course, I've seen how all these things are evolving until such time that I also tend to think that ALL is really a distinct structure and could only be seen when your knee is flexed to 90 degrees. But as you can show from your video, the fascia thickens as you flex to 90 degrees. Great. And so I think there has to be a new paper for that.
Yeah,
trying
I
to
agree.
correct all the information in the past.
Absolutely. And ultimately, we also need to understand, say like we detect some imaging abnormality, whether it was MRI or ultrasound. We have an ultrasound grading for ALL or ALC, I should say. And we're trying to prospectively correlate what does this mean to rotatory instability of the knee in the context of ACL injury. And, we are just trying to figure out, ultimately, we do these research to help our patients. So, we wanted to see if there's any need for, aggressive reconstruction repair, or this is something that we, as a physiatrist, can even play a role, maybe injecting, prolotherapy to tighten the ligaments, complex or PRP or other things. And I think there's a paper that actually suggested ultrasound-guided ALL repair. I don't know if you saw that, Dr. Castro.
Yeah, that's right.
Yeah. So it's really interesting. I think it's really interesting world because it's an extraarticular structure. So we may have a role in treating this too. So I think, but then before we get going treating it, we have to do due diligence, making sure this warrants a treatment. So that's why actually when I evaluate ALL or this structure for clinical practice, which I've been doing now for 5 straight years, 4 hours a week, every week, for Freddie's ACL deficient knees, I always evaluate contralateral normal side. And you do see pathologies in this area without injury history.
I have a question for you, Ken. You've shown the microvascular imaging of the medial meniscus, right? The question is, because you have shown us a very interesting comment about the imaging that is highlighted when there's an injury of the medial meniscus. So what is the implication of this? Do we need to do a surgical procedure, or do we need to be more conservative, or do we need to
so the application that I think I'm using so far for microvascular imaging is for the ACL. So I have used ultrasound microvascular imaging to evaluate if there's any difference in blood flow amount, volume, compared to the contralateral normal side in ACL deficient knees.
Okay.
And for those patients who sustain partial or full ACL injuries, microvascular imaging can show you 100% of the time increased blood flow as measured by pixel counting. So we'll use the ImageJ system to actually count the amount of areas that's covered by the microvascular color signals, and then compare that with the uninjured side using exact same setup. And what we are finding is if you see increased vascularity on ACL, in cases such as if the patient is guarded and you are not able to trust that, anterior drawer or Lachman examination, load and shift, if those are not possible because of guarding, I'm trying to say maybe increased microvascular flow can be used as a surrogate imaging modality on the site of an injury, as opposed to needing to wait for MRI. In fact, one of the volleyball players we recently evaluated, we were able to get her on schedule prior to MRI being done, so that we have a plans and secure the surgical spot without delaying care using microvascular imaging. So we are actually looking at this, and I really didn't think that was the right thing to do because microvascular imaging in sports medicine is still very new. So then besides that, no one knows what the normal amount of blood flow is in the physiological state for ACL. So, but then of course, Freddie who comes over, right? And he wants to publish more ACL papers. Nothing else matters, right? So then he comes on and he's like, find out what the normal blood flow is. We're gonna start using this for ACL injured knees. I'm like, what do I do in this case, right? You just basically suggest the impossible and you just have to deliver it. So that's how we started. So that we started playing with it and we called the company to really understand the technology and the algorithm behind it. And then we concluded that maybe using a normal side as a reference point in terms of setup, because we have to change the setup like a color game, much like a power Doppler. Interesting. I don't know if you have much experience, Dr. Castro, using microvascular imaging.
No.
It shows
okay, go ahead. Go ahead.
It shows the different groups of blood vessels than power Doppler or color Doppler shows. So it's interesting, like, the Achilles tendon and patella tendon, we do tendon scraping and other things, I'm sure as you do. And you put the transducer, you say exactly same location in the same person, and you use the power Doppler, then you see a group of blood flow signals, right? Then you immediately change to smart microvascular imaging. It will show you blood flow, but in the different areas. So that comes to show you that these two software, color Doppler, power Doppler versus SMI, they are showing a different group of blood vessels. So this is the area where we haven't evaluated the musculoskeletal world. And I'll talk to you a little bit about it, because we are getting ready to publish a paper that comprehensively review the use of microvascular imaging for musculoskeletal injuries. I'd like to pick your brain on it. Maybe you can actually review it, and maybe we can co-author this soon to be done comprehensive review.
Yeah.
But
of course, I'm looking at the shoulder. I'm also interested with the shoulder with microvascular imaging, because I read this journal about comparing the infra and supraspinatus problem, and then they're seeing actually early changes in the supraspinatus as compared with infra, although we're actually looking at the ratio of the fatty degeneration that happens in infra in relation to teres minor, but there's an early change that happens in the supraspinatus. So that's where I was trying to look at it. But in the knee, it's a little challenging, because if you're looking at the ACL, you have to have a very good ultrasound to be able to visualize that area there.
yeah, you get good at this, like as I started, just look at J paper and other papers, and then you're like, you don't even believe your own skills, and like I, because Freddie said you gotta see this, so I'm seeing it, but I'm not really sure. But then you get really good at it, like over time you really get good at it. Yeah. So now I'm able to confidently see ACL even with really steep tibial slope. Tibial slope usually challenges because we are looking at it from the anterior side, and it casts that bony shadow. But there are ways to actually sneak the beam in to be able to visualize the septum, AM bundle, and PL bundle. So, I'm able to do it. With regards to the shoulder, we are actually embarking on a study that uses microvascular imaging after standard rotator cuff repair versus rotator cuff repair using a patch, biological degradable patch that's supposed to provide a matrix for that tendon bone integration to be smoother. And we think that vascular evaluation can inform us. And we think that with the patch, maybe there's an increased initial blood flow. So basically it will hasten the recovery quicker. So we are getting ready. We just got IRB approved for that. So we are looking at 5 patients with regular standard rotator cuff repair, and compare that with a 5-patient rotator cuff repaired with the patch, biological patch, biometrics patch used. And we are going to evaluate the difference in the blood flow to the area using microvascular imaging. There are 3 machines now that can do this. One is from Samsung, the other one is from Canon Applio, and then final new one is a GE E10.
Yeah.
E10 has a microvascular imaging.
Yeah. The E10. Yeah. Well, thank you, Ken, for the lecture and for your time. And
thank you.
I really look forward to seeing you in person. I don't know when.
Sounds good. Thank you so much for your invitation.
Always keep in touch. We'll try to do something and write more chapters, maybe.
Yeah. I need to send it to you. Like, we just finished the 17th revision on your sports medicine chapter, and it's looking really good. So hopefully we'll get the first time passing grade.
Okay.
Dr. Jim?
Yes.
Add something. Hi. Dr.
Hi, how are you? Good morning.
Morning from the Philippines. So I'm already, I was just thankful about your study about the medial meniscus and the bulging of it. And I'm looking forward to that too, because sometimes we see some spurs and then we see it just bulging. And then we get to think to ourselves, is this pathologic or is this normal? And then you just kind of and so your study, I was thinking, wow, this is something that you should really publish, and that we should see and look at if it's normal when it's bulging that way. Thank you very much, Dr. Ken.
Of course, and thank you so much for your comments about the meniscus extrusion and bulge. I think one things that we all need to look at is to see if the injury to medial collateral ligament or tibial collateral ligament concurrent with suspected injury to the meniscus, such as posterior root tear, would make any differences. Because, you know, there's a phenomenon called pseudo extrusion or pseudo meniscus extrusion or bulging, where if you have an injury to the fibers of MCL, then people think that meniscus would come out not because of the injury and loss of contact of meniscus to the tibia, but loss of resisting force from the MCL and laxity of the MCL. So that is next thing to do on our list. But if you can even clinically evaluate, hey, this patient with MCL plus meniscus injury tends to extrude more than patient with the same meniscus injury but without injury to the MCL. I think those are the patterns that we need to begin to understand so that we can make comments on this is normal, this is abnormal amount, and ideally, if we can make comments on the meniscus function without needing MRI, by looking at how meniscus moves.
Correct.
So movement of the meniscus used as a surrogate sign of injury that makes the meniscus incompetent. Therefore, a surgery is needed or intervention is needed. I think that will, you know, progress our field and progress the position of ultrasound in musculoskeletal practice. But it does take a lot of, you know, effort from basic science. If we are to have access like, you know, robotic machine, then we can do these fancy studies. But then we also need a clinical output, someone who likes to evaluate meniscus bulging or, you know, extrusion, to continue to apply and to just keep taking pictures and videos and have like established protocol and, you know, observe what happens to our patients. And I think those things will help. We are actually doing the same thing for the labrum in the shoulder. We're trying to use the anterior translation amount and patterns of the meniscus movement to predict the labrum movement to predict the type of labrum tear without needing to visualize actual tear, because, you know, it's all not about actually seeing it. It's more about understanding what does this particular injury mean to the stability of the shoulder or the knee joint. Right. So ultrasound really changes that sort of like old school thoughts of I must see the tear size, tear locations. It matters only to people who are operating on this to prepare for surgery. For us, it's all about function.
Right.
So I think ultrasound is really, really going to help us, you know, advocate for our role in caring musculoskeletal injury, in caring for athletic injuries. But, you know, it takes time. It takes a village and people like ourselves here. But thank you for your comment.
Okay.
Thank you very much.
Thank you, Dr. Ken. I appreciate you for your.
Thank you.
So-
Dr. Kessler, take care of your voice too.
Yeah.
I feel bad.
Thank you. Thank you. God bless.
God bless. Thank you.
Thank you.